So it's very nice, and we are honored to have our first presenter. He's a very well-known gynae-onc, not in Egypt, not in the region, but all over the world, Dr. Ahmed Seketory. He is the Vice President of Egyptian Gynae-Oncology Society, and he is mentor for many of us, and he was the first one to introduce the concept of subspecialty of gynae-oncology in Egypt. Really, he is going to speak about molecular profile and classification of epithelial ovarian cancer. The floor is yours, Prof.
Thank you very much, Basil. This is too much for me. I'm very glad to be here, and I'd like to welcome all our guests, eminent gynae-oncologists, that we feel proud to have you with us here. I'm going to talk to you briefly about really molecular classification and profiling in epithelial ovarian cancer. From my humble opinion as a surgeon, not really conversed enough to pronounce the difficult names of the immunotherapy drugs and all these drugs. But these are the contents of my talk, and I have no undisclosed interests. If we are going to talk about the introduction for ovarian cancer, so in Egypt, ovarian cancer is the fourth cancer that affects women, or the fifth cancer. Alternates between the fourth and fifth ranks, and it's a deadly disease. The incidence is more or less similar to the international incidence, with about 5 per 100,000 women. This is a disease of the older age group, so the incidence goes high up as the age goes up. And in Egypt, about 45% of ovarian cancer ladies are younger than 45 years, and this is because of the population pyramid characteristics in Egypt, where there is a huge number or percentage of the population in the younger age group. So the incidence is the same, but the frequency of the young cases are great, and that puts an emphasis on trying to improve ovarian cancer management, so that the lady, which is half of the community and cares for the other half of the community, maintains a good health to look after her family and herself, obviously. The thing that is really putting more importance on what we are saying is that ovarian cancer incidence is expected to rise, and we are approximately reaching 5,000 cases, or near 5,000 by the year 2030-35, and this is the benchmark for the global standard development goals, and reaching 6,000 cases, new cases a year by 2050. At any one time, 6,854 ladies living with ovarian cancer in Egypt. That's a huge number, most of them having recurrences, most of them towards the end of their lives. So the burden is huge on the community and on the healthcare facilities. So anything to improve care is expected to reflect positively on the health care of the population. If we look at the initial histological classification, this is the classification that we are used to. I'm not going to repeat it, but it's neoplasm from the coelomic epithelium, from germ cells, from the stroma. And so far, around 8% absolute increase in the care of ovarian cancer up to the year 2009. Relatively, if you get percentages, is less than a quarter of improvement. That does not reflect the improvement that happened in other cancers or cancer sites. And more recently, if you look at the increase, for example, in Australia, which is really a system of a very good health care and good registry, the increase from the year around the year 2000 or the turn of this century to 2020 is just 8% improvement. No major breakthroughs in surgery, so surgery remains the same, with the amount of residual disease as a cornerstone in the management of ovarian cancer. And that is maintained. That's the only thing that is maintained across all histotypes of ovarian cancer. why do we need more classification and profiling? Just to care for these ladies. If you think that the lady on the right with this massive ascites is a very high-grade ovarian cancer, I tell you no, this is one of my cases. She is a borderline tumor that stayed in remission for 12 years. And when she decided to have fertility surgery, assisted treatment, she had her ovaries removed 12 years ago and the omentum and all that, kept the uterus, started having high-dose estrogen to prepare the uterus for a donated egg, and she recurred and she died within 3 months. The other lady progressed on platinum treatment. So, where to go? Thinking without awareness is the main dilemma of human existence. You keep doing everything all the time. You just have to reflect on what you're doing and try to think differently. Well, the WHO is keeping pace with changes in the histological classification of ovarian cancer. And you see now in the WHO last classification, the different histotypes are embedded in the classification, like the high-grade serous, low-grade serous, mucinous, endometrioid. So the knowledge of the different histotypes have been, acknowledged by the international societies and the international authorities that provide guidance for physicians across the world. Now, if you look a little bit more closely at the classifications for histotypes of ovarian cancer, now we can classify them into high-grade serous ovarian carcinoma, which is 70% of the, or 75% of the epithelial ovarian cancer. And because epithelial ovarian cancers are usually, 95% of all ovarian cancers, so you can just take that 70% figure as if it is 70% of all ovarian cancers. And the low-grade serous carcinoma, 5%. And as you can see, the other figures, endometrioids and clear cells, 10% each, and the mucinous is 3%. Now, awareness is the greatest agent for change. So if you want to have a little bit more personalized treatment, improved outcome, you have to have more insight. You have to have more knowledge about what you are doing. We just learned from an example of a couple of cases that the ovarian cancer behavior is not exactly the same. The expectations might not reflect what happens in reality. Some patients really have marvelous response to the extent that you open their abdomen after a disseminated disease and everything is vanished. They just feel a very, very clear abdomen. To the extent that we talking yesterday about laparoscopic cytoreductive surgery in a metastatic disease following neoadjuvant. And others just progress to the end of their lives. So everything is different. The precursor lesions, the pattern of spread, molecular events, and during tumorigenesis, and response to chemotherapy and prognosis, they're all different. The high-grade serous carcinoma, which is 70% of ovarian cancer, usually presents in advanced stage and initially good response to standard chemotherapy, but the majority will relapse and eventually will develop drug resistance after relapse, and 5-year survival is still a little bit less than 50%. So those who are saying about 2,000 new ovarian cancer cases a year in Egypt, around 1,100 deaths a year from ovarian cancer in Egypt. So the figure 80% really you can just roughly take it as a fact in ovarian cancer. 80% present in the high-grade ovarian cancer, 80% presents in advanced stage, 80% will respond to surgery and chemotherapy, 80% will relapse within 2 years, and those who relapse, 80% of them will sadly die within further 2 years. And those who relapse, and they have been sensitive to platinum, they show another, effect or sensitivity in the region of about 60%. Those who have partial sensitivity, you start getting very poor results from rechallenging them with platinum. And you just lose those who have been resistant to platinum and refractory to platinum. And that's the big challenge. Ovarian cancer, epithelial ovarian cancer been treated surgically the same way, improvement in the management outcome, heterogeneous and slow. And as we just mentioned, personalized treatment will offer good care. Therefore, you need to know more, and if you need to know more, you need more research. And this is a rare disease, and this is a fatal disease. You can't just experiment on humans. If you do this in some clinical trials, there is an ethical obligations not to do, basic research on patients. Just see them to the end of their journey. To create animal models, really, you have. This is just a summary of what we are doing, or what the research into ovarian cancer, preclinical research, is centered. And it's using genetically engineered mouse models, and you use this. This is the mouse that has been engineered with a gene that is mutated that can make the mouse develop cancer. And here you can study the oncogenic process, tumorigenesis, and the interactions between different genes and all this. Or you just get stem cell or tumor cells from a human and implant it in the mouse, underneath the skin of the mouth, for example. And these models, you can perfectly study the drug effect and treatment interactions. The laying hen model, and then, because the commonest cause of death in the hen is ovarian cancer. If you do not, eat the hen before she dies, or she will die from ovarian cancer. And because she ovulates every day, at some point in her life, she ovulates every day. And that is the theory of the incessant ovulation. The greatest professor, Professor Fathallah, he's sadly left us last month. God bless his soul. He pioneered this theory. So the laying hen model, if you get a creature that can, that is going to develop ovarian cancer, then you can give this hen some drugs, some treatment to prevent her getting ovarian cancer. So you can study chemoprevention on the hen model. And there are lots of in vitro and in vivo models for immunohistochemistry studies and biomarker and molecular studies. The classification has matured a little bit to classify them into type 1 and type 2. With the type 2 ovarian cancer is the high-grade ovarian cancer, like the high-grade serous carcinoma and the carcinosarcoma and the undifferentiated carcinoma. And this is a rapidly growing, presents in a late stage. And the genetic instability is pronounced in this, mainly the TP53 and other genes, as you can see, but also notoriously the BRCA1 and BRCA2 genes. And this is the one that you see in the familial breast and ovarian cancer syndromes, and the theory of its precursor lesion is the tubal lesions. The other types, which is type 1, that's the low-grade serous carcinoma, mucinous carcinomas, endometrioid, and clear cell, slowly growing. The low-grade carcinoma, though, presents in an advanced stage, but have an indolent course, although it is a little bit chemo-resistant, but you have a very extended life expectancy even after relapse. The genetic instability is very minimal. As you can see here, if we separate these two groups, you find that the mortality, 10% in type 1, overall I'm talking about, but 90% in type 2. Usually early stage, apart from the low-grade serous carcinomas, but usually advanced stage like carcinosarcomas and high-grade carcinomas. The progression is slow in the type 1 and fast in type 2. These are the genes here, and the main genes in the type 2 is the P53 and BRCA1 and BRCA2 genes, amongst other genes with genetic instability and arise as a de novo or from stick. If you look at these categories again, here are the risk factors that we've just mentioned. This is the endometrioid ovarian cancer, and it has been associated with the Lynch syndrome. There are mismatch repair gene instability, atypical endometriosis in it, and similarly, clear cell carcinoma can be associated with endometriosis. Low-grade serous carcinoma can arise as, in a background of borderline ovarian cancer. We used to have the micropapillary borderline ovarian cancer, which is now considered as a low-grade serous carcinoma variety. Okay? There is about 10 to 13% progression of borderline into low-grade serous carcinoma. These are the genes that affect each category, and the chemosensitivity in the high grade and endometrioid is good, but all the other types, chemosensitivity, I mean platinum sensitivity is very low. We used to treat them all the same and expect the same results. As you can see here, the prognosis, overall prognosis, is favorable in the endometrioid ovarian cancer and true mucinous ovarian cancer. The potential molecular targets, if we know about these mutations and genetic instabilities, then you find that the BARB inhibitors and immune checkpoint inhibitors are very good drugs to use in the high-grade serous carcinoma, and luckily these have been incorporated into our standard practice nowadays. The others, okay, because of the rarity of the disease, you have still ongoing trials, as we'll see later. If you look here, endometrioid ovarian cancer, stage 1 and 2 comprise 80% of the presentation of this epithelial ovarian cancer. And this is, on the contrary, to perhaps 85 to 90% in the high-grade serous ovarian carcinoma. Ovarian carcinosarcoma, exactly the same presentation, very late stage. You get a late stage presentation in low-grade serous ovarian cancer, but the prognosis is very good. Indolent course, long life expectancy, even after relapse. Survival here, if you look here, 60 to 70%, 10-year survival in endometrioid ovarian cancer. This is except in the relapsed disease and the high-grade disease, and also in the high-stage disease in endometrioid. 10-year survival in the clear cell is very good in the early-stage disease. clear cell is high grade by definition. Nevertheless, majority present in early stage. That's why the prognosis is good. But those with clear cell late stage, the prognosis is bad. Mucinous ovarian carcinoma, if it is true ovarian, the prognosis is good. If you find small bilateral ovarian mucinous tumors, these are not ovarian, these are metastatic from another primary, usually gastrointestinal primary. Usually the true ovarian is a unilateral and huge ovarian cyst that follows the multi-step theory of progression, like the colonic polyps. Start as a mucinous cyst, then an area in it develops a borderline change, and then inside this area another area develops mucinous carcinoma. I'm conscious of time and coming to the end of the presentation. These are the useful diagnostic markers. Some of the endometrioid ovarian cancers, the high grade, get mixed with the high grade serous ovarian carcinoma. And the WT1 is an excellent marker to differentiate between high grade serous ovarian carcinoma and high grade endometrioid ovarian carcinoma, because the endometrioid is WT negative and the serous is WT positive. Also, the napsin is a very good marker for the clear cell ovarian carcinomas. You get more insight into the molecular markers, but if you look here, you can see that the picture started to get disentangled. I'm not going to go through the whole the slide here, but it's just we are beginning to identify certain pathways and certain molecular targets for treatment. These are some of the studies that get translated from our knowledge of the molecular pathways and molecular instabilities of ovarian cancer or different types of ovarian cancer. So you get here, if you had serous high-grade ovarian carcinoma, this is the treatment of choice. If you get low-grade, this is the treatment of choice, and so on and so forth. So we are starting to get into personalized treatment. And this is because of our knowledge and awareness. Okay? Exactly the same here. This is introducing the PARP inhibitors plus anti-angiogenic agents in ovarian cancer therapy and the results. And this is introducing immune checkpoint inhibitors in the recurrent ovarian cancer, So as the knowledge starts to increase, this will translate into your good management of these difficult cases. This is a couple. We are moved from the open HIPIC into the closed HIPIC technique. That's what we do. In this case, this is the first HIPIC I did with the cardiothoracic machine, not the HIPIC machine, because it was very expensive kit. So and it really went very well, and it was about 10-15% of the cost of the true HIPIC machine. This is the end of my talk, and we really need more research into the subject, more knowledge, more insight, and this will allow us to get more personalized treatment that reflects positively in women's health. Thank you very much.